First of all, I would like to introduce our keynote speaker or the guest speaker, Dr. Anand Vinekar. And he needs no more introduction. And he is a known figure in ROP, national-wise and internationally. And he heads the Pediatric Retinal Department in Narayana Netralaya, Bangalore. And he is the founder and program director of KID ROP, which is a tele-ophthalmology program which has actually changed the way the screening and treatment of ROP is being done. And he has a lot of publications to his credit, including book chapters and journals. And he has been a key member in the new ICROP 3 classification of ROP. And with no further introduction, I would like to welcome Dr. Anand Vinekar for his talk on imaging in pediatric retina.
Thank you so much, and wonderful being back in Kerala as always. So what's new in ROP imaging? I'm just going to quickly talk about the Indian perspective and then end with where we're going from here. So the new classification, the imaging has become so important that in the new classification we are actually looking at bringing in not just fundus photography but other modes of imaging. So that's how important the whole scene is. And this is classically expanded in aggressive ROP. So even that term aggressive posterior ROP, posterior was dropped because even anterior disease can be very aggressive and severe. And the classical examples of this are only demonstrated by imaging and not just fundus photography, but as you can see here on fluorescein angiography as well. So this whole concept, if you train your eye to this very last photograph below of the angiogram, the blood vessels seem to have reached almost the ora serrata. But there's a lot of capillary non-perfusion going far more posterior. So this is a very severe posterior disease, but appears to falsely look like anterior disease. So that is again where imaging helps you understand. In fact, OCT has also made its appearance in the new classification, but not so much for helping to classify, but otherwise. Now, reactivation is another place where imaging really helps, and reactivation classically is talked about after giving anti-VEGF. So the reactivation can either happen at the original site where the disease was, can happen at a new site which is much more anterior, or can happen in both places. So again, if you have photo documented this in whatever form, drawings, but better photo documentation, angiogram, OCT to show how it's lifted, then it will really help you explain to the patient and safeguard your interests if you are going to do retreatment. Now, what are the newer imaging devices? So after the RETCam, which is considered the gold standard for wide field imaging, we now have the Indian camera, the NEO, which all of you all have seen. This is now commercially available within FDA and CE approval since 2015. But this device now has an angiography module as well, which has now come to market. And what's important here is that as we almost, they say 30% of Indian ROP now is aggressive ROP, which means at least 50% of those or more, we are going to be starting to treat with primarily anti-VEGF. Doing angiography both pre-treatment and to monitor treatment, and I'll show you at least 2 examples, is very, very useful because you don't know when to intervene as far as the retreatment is concerned. And then there are other low-cost devices which also do the job. They help in photo documentation, maybe not in a telemedicine model as yet, but these cameras that have been made by the Agarwal and the Gujarat group, these are modifications of your 20D using a smartphone. They work bedside, they are useful in photo documentation. Now I'm going to talk about angiography in the realm of anti-VEGF because that is where it's really important. So this paper coming from the Chinese group showed that there are at least 3 or 4 different patterns of how these blood vessels grow and then stop growing. So there is a vascular arrest. So we know recurrence, we talked about recurrence and reactivation. But there's also something like these blood vessels have started growing to a point and then they don't go any further. And that's when you have to take a call to do the laser treatment or in very rare cases maybe re-inject. So these patterns are now described and some of these patterns mimic something else. For example, in our Indian ROP Society group, there was someone who showed a sort of a telangiectatic nodule in the periphery 5 years after giving anti-VEGF. So, and it almost, many of them, like a spotter said, this could be Coates disease, this could be ephemia. So, all kinds of abnormal findings are beginning to emerge after anti-VEGF, and it's really important to document these because that's when you know when to do the treatment. So, for example, here, it can be as bad as disc leak right there in the posterior. It can be as peripheral as a proliferative, as though it's a regular stage 3 in the lower column. So these are all that's been described. I'm just sharing a couple of our own cases here. So this is like a very bad posterior zone 1 aggressive ROP, which was given Avastin, bevacizumab. 10 weeks later, the plus is gone, all of that's gone, it's doing well. But almost 3.5 to 4 months later, there is a very bad, very posterior vascular arrest. The vessels don't seem to be growing any further than this. Now, there's a debate on whether you can give a second injection or not and why it's not usually preferred. But at this point, when you have this picture, which looks so innocuous, you can hardly tell what's going on in the periphery. You can hardly tell that more than half of the retina is literally bleeding with avascularity or ischemia. So angiogram helps. And that's when you have to complete it with the laser. There are now guidelines going to come out shortly, how long to follow up and when to do the treatment. Now this is 3 months after injection. Both eyes had a recurrence, with one eye having a notch recurrence, as you can see here, and you have to go in and treat it. We've tried avoiding the notch and waiting for further growth, and we find that another 3-4 months later you have to come back and treat the notch, and this time unfortunately maybe under sedation, because the child has now become 10 kgs. And then don't think that all recurrences are symmetric. For example, both these occluded avascular retinas, aggressive ROPs were given the same injection on the same day, but one comes back with a recurrence right there, almost looking like an early 4A, like child misses follow-up and comes with a horrible looking recurrence in the left eye, whereas the right eye looks very innocuous. The blood vessels are just going forward. So of course we treated the left eye immediately, and the right eye 3 months later. We were hoping that the blood vessels will grow further. They grew a little bit further, then ended up with persistent avascular retina, which was eventually treated. And this was the final outcome. Now, I just want to show you here that despite one eye having vascularization almost till zone 2 anterior and the other one having that 4A picture right there at zone 1, their vision is equal. The refractive error is almost equal. So one often thinks that, oh my god, if I do very posterior laser, I will cause a very high myopia or I'll cause all of those issues. This is just to show you that, of course, this child has undergone a lot of vision rehabilitation and so on. It just didn't happen by accident. But the point is, at the end of a year, the vision is equal. And the refractive error is also comparable. Now this is what happens if you inject and laser but incompletely. This was treated elsewhere, came to us as a 1.5-year-old child. So you can imagine 1.5 years after giving injection and laser, because it's done incompletely. Look at the picture on the right. Would you worry that this is going to be as bad as this on the angiogram? Maybe not. So now coming to OCT. So OCT, I've just spoken about this a couple of weeks back, so I'm going to go a little faster on this. That today we are able to do an OCT of a baby who's a few weeks old and look at all the layers that are coming or not present and then correlate that with vision. So that's really important, and histopath studies have shown what we are seeing is what's actually happening. For example, the RPE is right below, but on top is the ellipsoid zone, which is growing sequentially from 38 weeks as a single layer to a 48 weeks when it becomes a 2-layer. So that means this baby was not born with this layer, it came after some time. And our attempt has been to see whether any of the delay of these processes has correlated with any poor vision or not. Similarly, we found this macular edema, which is now called macular edema of prematurity, which is very transient, happens between age 37 weeks and age 50 weeks, but which can correlate with vision even at the end of the first year, can cause slight hyperopia at the end of the first year. So this has been our attempt to look at some of these events that are either delayed or not happening and correlated with vision. Similarly, OCT angiography has been a new tool. This was our very first case report where we looked at the new vessels that were not just on top but were also deeper, and we are able to look at a slightly older cohort, and these are 3 groups. One group that had no ROP, one group that had some ROP that went away, and the third group is completely normal. So and you can see that all of them, despite having 6/9 or better vision, they still have abnormal looking foveal avascular zones. So normal ophthalmoscopically, normal visually, but structurally abnormal. And it all goes down to their OCT changes and OCT angiography changes as well. We are also now able to check the contrast of babies few weeks old and correlate that using these special paddles and correlate that with vision at the end of 3 to 6 months. Universal screening through imaging, you are not only able to pick up for ROP, but other conditions as well. In this study, up to retinoblastoma, that was in preterm babies, and this is a universal study paper where we found that about 6.8% of conditions that required treatment were picked up in the first 72 hours of life if you do it. Imaging can also be used to train people across borders. And I'm going to finally end with machine learning or artificial intelligence. Today, India has done a good amount of work in ROP AI. We are now to the point where we are able to look at an image, segment that image, figure out whether this baby has a stage or not, and integrate it with a telemedicine approach. So this is really going to help. For example, this is a machine telling you that the picture on the left could be a stage 1 and a stage 2, and the picture on the right could be an early stage 3. This is a machine telling you just by feeding it the devices. The accuracy is good, it's not amazing, but this is yet work to be done. So, thank you so much.
Thank you, Dr. Anand, for that wonderful talk. Any questions?
You don't need to do it on GA, but it is done in the OT with the anesthetist standing by. So an IV access is obviously important because we are giving an IV fluorescein. Some of my friends have tried the oral fluorescein, not very useful in aggressive ROP. By the time it comes into the circulation, it's very poor. So just exactly the same precautions that you would take for laser, you would take for angio.
Any special cases where you prefer doing an angio, or do you do it in which
We are now
case?
doing it for almost all cases of aggressive ROP. We try to do it if we are, injection is our plan of management. We try to do the angiogram a day before because we feel somehow we are contaminating the field by running the camera over the eye. So we do it a day before and then take the baby into the OT straight away on the day we are giving the injection, or following day later.
Before the initial treatment?
Before the
Initial treatment, or?
Unfortunately, we don't have too many of those because these are very sick babies directly come in for the injection. But we have almost for all of them after they have been injected and before we do the laser therapy.
At the time of recurrence?
At this time of therapy.
In some babies who have a spontaneous regression of ROP, but they tend to have persistent avascular retina, do you recommend FA in such cases?
So the recommendation now is if the persistent avascular retina is more than 2 disc diameters, one has to do the treatment. If it is less than 1 disc diameter, then you don't have to do the treatment.
But ROP has regressed, like no ridge.
Correct.
You just have avascular retina.
So that is a problem. So now there is a definite recognition that avascular retina is a problem because as other studies have shown, they have a 14 times higher chance of retinal detachment as young adults and as adults. And it literally becomes an FEVR now. You've sort of converted the phenotype. So laser is a definitive therapy. The point against giving another injection at that time is that, see, another injection will only further reduce the VEGF load, which is already very low. Now you want VEGF for the blood vessels to grow. So giving another anti-VEGF is counterintuitive. So laser is, the only difference between doing laser in PAR and doing laser primarily is that we have not found the blood vessels growing over the lasered bed. Whereas if you do monotherapy with laser, you almost always find the vessels growing into the lasered area. So that is sad, but if there's a way to maybe reduce the anti-VEGF dose and do a titrated dose, it might work.
Thank you.
What maximum time you prefer to treat such babies where there is a mark?
So I'm talking on behalf of the society. We are now trying to come up with a guideline saying 48 to 52 weeks or 4.5 to 5 kgs. There's some rationale behind that, we can discuss that later. Or if your facility has like, okay, I will do it under general anesthesia, you can push that for way longer. But if you are the kinds who will say, I want to do it under topical, 4.5 to 5 kgs or 48 weeks minimum, unless there's a recurrence. So we're not talking about recurrence, we're talking about PAR, 48 to 50. Yes, correct. So the Samira Kori case, if you were there in the previous session, in that you cannot combine a diagnostic consent with a therapeutic consent. And clearly FFA is a diagnostic consent. So definitely yes. In fact, we can't even take the adult angiogram consent that's there in our hospital. We have to take a separate one. 0.077 ml per kg is the dose.
And sir, about the universal eye screening, what is the government of India suggest now, like for routine eye checkup you need for, not for ROP?
So under the RBSK which came out in the 2013, they said universal screening should be done.
Not all should be done like.
They unfortunately don't have operational guidelines for non-ROP conditions, so it's left to us. So our program where we are doing universal in Karnataka in the government hospitals, just to give you a sample difference, we have covered about 220,000 ROP sessions, but we've covered just about 18 to 20,000 of universal screening sessions. So So it has not caught on even in the government sector, which has made it mandatory. But it is definitely something to think about and talk to your pediatrician about. Thank you.
Thank you, Dr. Anand, for that wonderful talk. Now, senior consultant presently working in a Giridhara Institute, very passionate about ROP and treating ROP babies. So she'll be talking about non-ROP surprises while doing screening for ROP babies.
Good morning, everyone. I thank KSOS and Dr. Divya for giving me this opportunity. Recent advances in the neonatal care has increased the survival of more and more preterms, but this has also increased the morbidity, and visual system in particular is exposed to much more stimuli than a full-term healthy infant, including oxygen drugs. These babies will have other comorbidities and all that can increase the occurrence of other ocular pathologies. Early detection and treatment definitely help to improve the outcome. However, the literature is very limited. In this study by Dr. Vinekar and Chaitra et al., which was based on analysis of the retinal images, they detected a prevalence of 7.6% of other ocular pathologies in these premature babies. And the point here, 1/3 of them required intervention. In our observation over a period of 1 year, our prevalence was 3.74 and 20% of them required intervention. We'll go through some of these case examples. This is a baby, 28-weeker. Routine ROP screening was done, but at the next visit, parents complained of a swelling in the lid, and they said it occurred because of the screening, and they were actually not related. Then I had to sort of convince them, and we noticed that in fact there was a swelling in the right lower lid, soft cystic swelling. Possibility of a hemangioma was considered, confirmed with MRI, and baby was treated on oral beta blockers. After discussing with the pediatrician, baby responded well to treatment, but please note that this baby also developed significant astigmatism and strabismus in that eye. So it's not important we diagnose that and treat that. Of course, hemangioma has a good prognosis. We should also take care of the associated ocular problems. This baby, another preterm, third of the triplet, had many neonatal issues, born to a COVID-positive mother. Baby did not have features of ROP, but the view was hazy because of the cataractous changes in the right eye. Titers were not specific, but ultrasound revealed persistent hyperplastic primary vitreous, and so pars plana lensectomy with vitrectomy was advised. In these premature babies, apart from the routine causes, they are more susceptible to develop cataract, either due to their systemic conditions or due to their coexistent ocular pathology. And please remember, the treatment of ROP itself can increase the risk of cataract in these babies. Some findings can be a clue for the systemic diagnosis, as in this case, who had an extremely pinpoint pupil. This picture is actually post-dilatation. We can see the dilatation is very poor, iris was a little hypoplastic. We did not know what was happening, and through the small pupil, all we could make out was a hypopigmented fundus. So systemic workup was done, which revealed features of renal dysfunction, leading to a diagnosis of congenital nephrotic syndrome. And this combination is seen in a condition known as Pearson syndrome, which is due to mutations in the gene encoding for laminin B2. This laminin is present in almost all the basement membranes, including that in the cornea, lens, retina, etc. So it causes pan-ocular anomalies, of which microchoria is the most consistent feature. So any baby with an unusual microchoria better to do a renal function, and conversely, in nephrotic syndrome of unexplained cause, it's better to do an ophthal evaluation. We also came across various congenital anomalies, coloboma, because these premature babies are more likely to have growth arrest and development. So look for any associated syndromes, take care of their refractive error, and long-term follow-up for retinal detachment is also important. Cystic fovea, Dr. Anand has already mentioned. We really don't know the cause, but again, long-term follow-up is important because they can have lower visual acuity in the long term. This baby, another preterm, had sepsis, shock, hepatosplenomegaly, antenatally itself high drops was detected. ROP screening, baby was kept for ROP screening, and the titers are also abnormal, but on fundus examination there was significant vitritis, yellowish necrotic lesion over the macula in both eyes, so we suspected toxo, titers were abnormal. CT scan showed multiple calcification, confirming our diagnosis, and following appropriate therapy, the lesions resolved, but unfortunately with a bilateral macular scar at this age. So we have to understand that ocular lesions are the most common finding in congenital toxoplasmosis. Always do look for intracranial involvement, and this can coexist with ROP. Retinal hemorrhages are the most common finding that we come across. Usually they are benign, self-resolving, but a hemorrhage right over the macula is little more of a concern because of its amblyogenic potential. So we don't know the impact of the retinal blur due to a macular hemorrhage has anything to do with the optical development which usually happens in the immediate postnatal period, or in other words, does amblyopia or anisometropia which we detect later has its genesis in the postnatal period. We look at the next case. This baby, a 30-weeker, was ventilated, had pulmonary hemorrhage, anemia, shock, sepsis. At the first screening, there was incomplete vascularization in the right eye and mild ROP in the left eye. But at the next visit, we saw this unusual creamy lesion right over the macula in the right eye. We had no clue, considered toxo as a possibility, asked for the titers, started antibiotics. A week later, the results came. Only CMV was positive but not specific. CSF study showed meningitis, but the culture was sterile. All imaging was normal. Next visit, it looked as if there is some kind of exudation around the lesion, and slowly it appeared as if the lesion is projecting into the vitreous cavity, but there were no vascular changes, no vitreous haze, and to our surprise, the next visit we saw fresh bleed all around the lesion. Again, we were not sure how to proceed. The baby was systemically stable on our antibiotics, and we waited, and to our great relief, the hemorrhage started clearing on its own. But the baby was lost to follow-up after that, came to us 10 months later. By then the baby was 1 year old, fixing and following light, orthophoric, anterior segment and fundus was normal, but retinoscopy showed high myopia in that eye. I really don't know the diagnosis. Maybe if we had imaging, we would have got more valuable information. But how to explain this unilateral high myopia in this baby with a pre-existing macular hemorrhage in the same eye? I'll come to my last case, a very sad story. This baby was not a preterm, born at 37 weeks by normal vaginal delivery. There was no history of NICU care. The pediatrician noticed significant lid swelling and discharged on day 3. And there was a suspicion of herpes in the mother. So they started on topical and systemic antibiotics and antiviral. And this was a presentation. You can see bilateral proptosis, periorbital edema, very tense lid edema, diffuse conjunctival congestion, chemosis, hazy cornea, and total hyphema in both eyes. Ultrasound showed vitreous echoes, significant retinochoroidal thickening, edema in the Tenon space. Systemically, but baby was stable. We considered these differentials, ordered for all the investigations. Unfortunately, all the culture report from all the samples was negative. Torch was not conclusive. A PCR for virus was negative. Maternal screening was also negative, but MRI showed abscess, likely of bacterial origin. And in spite of our antibiotic therapy, lid edema persisted, but now we can see the whole anterior chamber was filled with exudates. Ultrasound showed definite worsening, and there was calcification of the ocular cords. AC type was attempted, but it was dry. We proceeded with intravitreal injection of antibiotics in both eyes. The next day, at least there was some improvement in the lid edema, but exudates persisted. We decided to proceed with surgery under extreme visual prognosis. Both eyes, lensectomy with pars plana vitrectomy was done, and since the cornea was so bad, it had to be combined with the penetrating keratoplasty. Intraoperatively, the cornea was so thick and full of infiltrates, vitreous was filled with exudates, retina was necrotic, and choroid was avascular. Sample was sent for PCR. 1 week post-surgery, the graft was intact. MRI showed improvement, but the PCR came for positive for bacillus cereus. Both eyes eventually became thiesical. This was a very challenging case because of an unusual bilateral hyphematous presentation, lack of microbiological growth, and difficulties of surgery in this neonate. So we know that neonatal endogenous end-off is very rare, but when it happens, it can be a potentially blinding complication. It's even more rare due to bacillus cereus, and this causes very aggressive infection because of the rapid multiplication of the organism and its ability to produce toxins. These toxins are highly harmful to the Muller cells and cause severe retinal destruction. So this is a condition where identification and treatment has to be done in a matter of 24 to 48 hours. And this emphasizes the importance of ophthalmic evaluation in neonatal septicemia. So to conclude, premature babies are more sick, so much higher degree of clinical suspicion is needed. Imaging, as has already been said, is definitely important to document and monitor. It also facilitates cross-consultation. Early detection will help in improving the outcome, and detection and reporting will also help to improve the awareness among all the specialists concerned. And finally, we need to have a protocol to ensure sustained follow-up and to see if there is any sequelae of these pathologies. Thank you.
And maybe those cases which we later label as amblyopia, we might be getting more of clues by doing this universal screening. Yes. I think Dr. Anand, could you add some of your experiences?
The case that you talked about high myopia after. We've had a few of those, and when we were looking at what is the possibility of these cystic foveas going into that, we were looking at a theory saying that if emetropization goes wrong at the critical time, then it's a sort of a feedback for the eye to grow longer. So if you did the axial length in that eye, you'd find it's actually axial myopia. So somehow the eye tries to protect itself from a poor hazy vision at the critical time of emetropization. And then up till 2 years they say there's myopia, which you maybe can take care of with at least prevent.
Thank you.
Thank you. Now I would like to welcome Dr. Anubhav Goyal, and he is consultant at the Giridhara Institute, very passionate about ROP, and he'll be talking us about classification of ROP, what is new in treatment also.
Thank you, ma'am, for the kind introduction. So my topic is on current classification and treatment, which I already, some part of it already Anand sir has discussed. So I'll be concentrating on this only. So as we all know, ROP is the most common cause of childhood blindness, and we have to do a major, we have to understand a lot in ROP, and we have to do a lot in ROP. So ICROP initially was classified in 1984 with the basic classification on zone, extent and staging, which further in ICROP 2 it was added APROP and Pre Plus was added in 2005, but because of lot of shortcomings and limitations in this classification, in innovation in ophthalmic imaging, and now the extensive use of anti-VEGF in ROP treatment and change in ROP spectrum worldwide with larger baby presentation of ROP in larger babies. This ICROP 3 has been introduced in 2021, and this classification was given under the chair of Michael Chang in 2018 with many continents contributing to this classification. So this classification has a modified explanation under 7 points. There is APROP has been changed to AROP, ROP regression, which is a new terminology, ROP reactivation, and PAR. These are 3 new terminologies. They have redefined stage 5, and then they have redefined zone 2 and plus disease spectrum. I will be discussing all this. So as sir has already informed, APROP has been termed as AROP. It's more as the aggressive ROP because now more of the babies are seen with this aggressive ROP. Table showing difference between ICROP 2 and newer terminology between ICROP 3. This reactivation, regression, and peripheral avascular retina, which is introduced as a new terminologies in ICROP 3. While coming to management, the most important part of management is still the screening. We have to concentrate on screening because it's a very important thing and it has a lot of medical legal issues. Treatment comes next to it. As sir has already explained, this is the standard new guidelines of screening the babies. And coming back to the treatment, the first initial treatment for ROP was cryotherapy by cryo-ROP we get to know in 1988 because of lot of unfavorable outcomes which was not followed now. The second landmark trial came as ATROP, which shows the importance of laser in treatment in ROP, which shows decrease in unfavorable anatomical outcomes from 27% to 9% in 27% in cryotherapy to 9% laser treatment, and then anti-VEGF, which can be used as monotherapy or adjuvant therapy to laser or as a pre-operative treatment before surgery. This has further changed the whole spectrum of treatment and has reduced and has shown the benefits of treatment with significantly less unfavorable outcomes. So in the next slide, you see the unfavorable outcomes has reduced from 22% cryo-ROP to ETROP 9% to beta-ROP just 4%. This injection, anti-VEGF injection is very good, but there are some shortcomings. ETROP has also defined classification into high risk threshold and low risk threshold. So the high risk is type 1 ROP, which needs treatment. Low risk is just to be screened, not to be treated. So this is now well known and documented that zone 1 has to be treated with injections because the outcomes are better, and zone 2 has to be treated with laser, and laser in treatment in zone 2 has better outcomes. There are a lot of studies which are showing multiple anti-VEGF treatment benefits of ranibizumab, aflibercept along with bevacizumab also. Rainbow trial is a recent landmark trial which has shown the benefit of ranibizumab superior to laser treatment for a treatment of ROP. So this laser is still the gold standard treatment, and this is showing our case in which you can see after the this stage 3 peripheral vascular retina, laser marks has been given with near confluent burns. Anti-VEGF and laser has a difference. Anti-VEGF causes significant vascularization to the periphery without leaving much of damage or scarred peripheral retina, but laser causes significant scarring in the peripheral retina, which has further sequelae and complication in long later life. The major problem of anti-VEGF is it can have later recurrences as low as is shown the beta ROP shown that it can be by 16 weeks, but it can show as late as 1 year also. So very close, careful, long-term screening and follow-up is necessary especially after injection. Laser treatment is still the gold standard treatment for ROP. If you know the laser, there is the best treatment, especially for zone 2 ROP. Still, most of the doctors should, as our current guidelines, following anti-VEGF followed by laser treatment as a rescue treatment 2 to 3 weeks after the laser treatment. Once the zone 2 posterior vascularizes to save maximum part of posterior bone. Now come the posterior surgical management. Surgical management is divided into basically of stage 4 and stage 5. Stage 4A is does well with buckling and vitrectomy is ready for 4B and 5. So take home message, early screening and timely treatment plays a major role in ROP screening. ROP to be examined every 1 to 2 weeks until vessels mature and disease threshold are passed away. Treatment includes later treatment, anti-VEGF and surgery for stage 4 and 5. Thank you.
I have a question. You spoke about avascular. This is seen in babies which are treated only with antibiotics.
Yes, sir.
Not in babies.
Actually, sir, in normal vascularization of retina, major vessel and myelin branches grows simultaneously. But after anti-VEGF, we usually see major vessels growing, but small vessels might lag behind in peripheral vascularization. So that minor vessels which are lagging behind is the reason of peripheral vascular retina.
But the standard of care is still, even if you're giving anti-VEGF.
No, sir, it's not the
laser.
Laser is the standard.
That's what I'm
of care.
saying.
Yeah.
Even if you give anti-VEGF,
Yes,
laser
sir.
is given later.
Yeah.
It's not that only anti-VEGF is
No, it should not be given. Laser injection should be followed by laser once the posterior zone 2 is vascularized. At least posterior zone 2 has to vascularize.
To lecture on ROP, new classification and management, I called up Dr. Divya Balakrishnan, a very experienced and well-talented vitreoretinal surgeon with special interest in pediatric retina. After her long stint in L.V. Prasad Eye Institute, Hyderabad, she is now working in Little Flower Hospital, Angamali. Over to Divya, please.
Brief overview of what are the surgical indications and interventions in pediatric retinal disorders. And the main indications for surgery in these babies or infants are mainly retinopathy of prematurity, familial exudative vitreoretinopathy, persistent fetal vasculature, and in children, rhegmatogenous retinal detachment could be associated mainly with Marfan syndrome, Stickler's, or even congenital glaucoma. Why it is difficult to treat these babies? Because of the delayed presentation, because most of them would be brought to the pediatric ophthalmologist when the second or the better eye is involved, as the primary unilateral involvement may go unnoticed. And most of these etiologies usually would be bilateral, and other difficulty is the coexistent systemic morbidities, which makes it difficult for repeated anesthesia. It's important, unlike in adults, to counsel these parents regarding the expected outcomes, especially after the previous session on the medico-legal issues. It may not be always result in vision improvement, but it may help to maintain the vision, prevent the worsening, or even it may sometimes help to preserve the glow. So coming to first one, the familial exudative vitreoretinopathy. Even though we thought it was very unusual, but I do see at least 1 or 2 babies in the month in my OPD. So the classification, it starts from a vascular peripheral retina in stage 1 to total retinal detachment. And the main thing you have to remember is that this disease is bilateral, but it can have severe asymmetric presentation with severe disease in one eye and a mild stage in the other eye. And clinical course can be variable. And the disease spectrum is characterized by avascular peripheral retina with peripheral straightening of the vessels. They can have exudation, tractional or exudative retinal detachment. So how come the surgical management in this? When the patient present with retinal detachment, either it is rheumatogenic or combined. So this photograph is actually a post-scleral buccal patient following retinal detachment in FEVR. This is a one-eyed patient. Patient presented at the age of 24. You could see that the break was in the periphery and the buccal supported the break and it settled. And vitrectomy, these are advanced cases of FEVR. This was again a one-eyed patient. You can see this is the right eye was NPL, left eye was the stage 5, and after vitrectomy you could see that it's a silicone oil filled eye with a belt buckle effect, and on follow-up this baby actually improved to 20/160 with the high myopia correction. And these are other cases of stage 5. The aim of the surgery is to remove the membrane, and you can see that the retinal fault may not settle completely, but the vision could be maintained and the globe could be preserved. This again, the one eye of the right eye of this child, 16 years old, and the left eye was having 20/160. Underwent surgery. This is the poster picture. The vision did not improve much, but the globe could be salvaged after the surgery. You have to remember, once you make a diagnosis of FEVR, this is a progressive disease, it's a lifelong disease. The child needs to be under regular follow-up, and once you make FEVR diagnosis, it is very important to family screening and screen the siblings and family members to look for any subtle diseases in them. And again, if any newborn babies are expected, then you should counsel the parents for an early screening in these babies, unlike ROP, which we wait for 3 to 4 weeks. Another condition is retinose cases. This is also not very uncommon, and sometimes these babies may be treated or referred as retinal detachment. So the key points are the inner schizix wall, and you could see that both inner and multiple outer retinal breaks in these children. So the surgical indication need to be done when these babies present with vitreous hemorrhage or retinal detachment. And medical treatment in this usually used is acetazolamide or dozolamide drops, which in some patients maybe up to 25 to 30% of them respond to this medication. But the visual acuity showed some improvement, but it may not help to much of an extent. So this was a 4-year-old boy who was brought with a history of sudden decrease in vision following a fall, and he was not fixing with the right eye, and fundus examination the child was uncooperative. D-scan was done, which showed a membranous echoes inferiorly, and under anesthesia we could see the left eye fundus was showing macular changes. We were not thinking much in terms of retinoschisis because of the history of trauma. And this was the intro picture. We went inside and we did the vitrectomy. After clearing the hemorrhage, you could see that the inner schizix wall was there, and this is the post-op picture, which you could see that there was a avulsed vessel and the inner schitic wall. So this baby is doing well post-surgery. So whenever any child with a history of trauma, you have to be very careful, not just attributing to trauma. Look for underlying any diseases, especially sometimes life-threatening diseases like retinoblastoma. Next is persistent fetal vasculature. Most of them present to pediatric ophthalmologists with complaints of leukoporia or squinting, and the B-scan is one of the most important tool which will help to pick up the underlying behind the stalk, and sometimes they can have smaller axial length eyes and long ciliary processes. So you have to, the surgical management depends upon the extent of the disease, whether it is visually debilitating or not, and you have to differentiate that it can or be only anterior PHPV, or sometimes it can be posterior or combined. And as I mentioned, the intervention depends upon, or the route of approach will depend upon which type of PHPV it is. So this is a case where this is a 15-year-old boy who was being treated for observation, and presented to a pediatric ophthalmologist for squint surgery, and this was the picture. And we saw that the lens was clear. In fact, that was a retrolental membrane, and there was a clear space behind the lens. So he was taken up for lens-sparing vitrectomy, and this surgery would help to stabilize the vision over time. And this was a case wherein you could see that the posterior stalk was attached to the posterior capsule. So you had to go from the anterior route, and in these cases you have to be very careful. The retina can be dragged into the anterior or even to the pars plana. So don't go just from posterior route. Go carefully and depress and see where the attachment. Otherwise you may land up creating an iatrogenic break. And this was a 10-year-old mentally challenged boy who was referred as case of bilateral cataract with uveitis, extensively investigated for uveitis, and was treatment for 2 months on uveitis. And when we saw this child, he was having a close funnel retinal detachment in the right eye, and the B-scan in the left eye shows an inferior RD. And this was the intro picture of the better eye. You could see that the pigmented anterior hyaloid, there was a giant retinal tear, and the lower picture is the end of the surgery post-op. So this child actually became less readable and became mobile. So don't get biased by just seeing uveitis and label it as uveitis. Just take little effort to look behind. Coats disease is another one which many a times present with squinting and leukoporia, and again it varies from stage 1 to advanced stage 5 disease, and the management again depends upon the stage of the disease, starting from laser, cryo, and in advanced stage you may do surgical intervention at least to prevent the loss of the globe.
It's not directly related to your dog. One question which I ask our team in the hospital is, and Anand also can probably chip in. I mean, I find that you screen so many children for RO, I mean, premature children. Now, these are the children who are likely to have other eye problems also, including refractive errors. But what is the percentage of these infants who are really coming for follow-up? Because, I mean, many of them, I think, are lost. And, I mean, it's our moral responsibility actually to see that these infants are. So, is there any take-home message or some, I mean, nothing that you can do, right? Nothing that you can do. So, because, I mean, many of these conditions which you were saying need to be diagnosed early. I mean, that's only possible if there is some methodology of, the parents are educated that these infants have to be, because the parents are only bothered about other things. They are not bothered about the eye till such time when the child really experiences something, or the parents also become aware of either a squinting of one eye or inability to see properly, etc., which may be a little late. So,
I think the universal screening should become a part of all the neonatal screening actually. So like they do the Vira and all those tests, it has become a part of the neonatal follow-up, or the things which has to be done before the baby is getting discharged. So maybe doctors perceive it will be difficult to go and screen. Maybe that imaging would be the one which is the way forward to pick up these conditions early enough.
See, even after the treatment, and then we send them off, we send letters to them, but they don't come back because the child is suffering from other problems than the eye. So we take it more important. That's the main reason I find. One or two children are definitely come back because their needs come here. We have got our neonatology unit, they come back. Most of them are not coming back.
Now I would like to invite Dr. Meena. She's a pediatric ophthalmologist at Little Flower Hospital, and again she does a lot of ROP work also. So hand over to you, Dr. Meena.
At the outset, I would like to thank KSOS and Dr. Divya for this opportunity. I'll be speaking on the pediatric ophthalmologist's role. I'll be talking about what is happening after the retina matures and treatment is over. So one important thing that you need to do that at the juncture when the treatment is over, it's not over, like if your retinal treatment is over, like whatever lasers or injection, just inform the parents that you need to come back, and it's just like a lifelong follow-up. That is one thing you have to be very particular about, and I don't know if there are particular guidelines for screening and further follow-up of the baby, but in our hospital over the last more than a decade, we just follow a system whereby once the retina matures, we call them back after 3 months. And this is mainly to rule out any media opacities and to confirm, we again confirm the retinal maturity. So next to that, we call 6 months later. This is mainly by that time the child would have grown up a little bit, and now we do the vision check. At least you do a fixing and following of each eye, which itself can be helpful, and see if both eyes is fixing properly, and if possible you can use the vision appropriate charts for vision assessment if possible, which is time consuming but it's good, and also do a routine slit lamp examination. Now you have to reassess the fundus, but you can see that as the child grows, it's not easy to see the periphery of the retina, and many a times the pupil may not dilate also properly, but still try to see whatever much you can do and do a cycloplegic refraction. And after 6 months of maturity of the retina, we do the cycloplegic refraction, which we do with cyclopentolate, or if the child has any CNS issues, we use hometropy. Now, I'll talk a bit on our experience with ROP babies follow-up and what we have seen in the past more than 10 years now. Like, I feel that what we usually see are refractive errors. And these refractive errors, they have an early onset in aggressive ROPs. So nowadays what we do is that we call them back early, and maybe we are doing not much of screening, it's mainly referred patients. So we have seen that most of these patients turn back, and we counsel them so much before leaving them after the injections or laser to come back. And what commonest refractive error, as all of us know, is high myopia with an association of myopic astigmatism. That is what we commonly see. Now, coming to strabismus, definitely we do see strabismus, but in my experience what I have seen that strabismus is not that common. Especially you see strabismus like esotropia in cases of high myopia, so of high premature babies and those with aggressive ROPs. And also intermittent exotropia is also seen, which is more related to anisometropia. Now, when the child comes to you with strabismus, it always warrants a detailed retinal evaluation, even under general anesthesia, to rule out any macular issues like drag. Because sometimes you may not be able to visualize the macula in all these children. They may not be cooperative. Once they are beyond 6 months of age, it's not easy to see the retina completely and perfectly. So we used to do routine EUAs earlier, and we used to perform EUAs after 1 year of age, and this was mainly to see the periphery of the retina and to assess the intraocular pressures. But now we have restricted this to high-risk group because we were finding it so difficult to give the anesthesia and to get anesthesia fitness. So, and also we have seen that IOP assessment we need not do in all cases, because other signs of increased intraocular pressure itself can help us to get a diagnosis of any secondary glaucomas. And amblyopia, as mentioned, this is the most common, it is very commonly associated with high refractive errors. Especially in cases with aggressive ROPs, we have seen that their vision may not improve to 6/6 or 6/9. Most of them will stop at 6/18 or 6/12, and this is, we don't know what the reason is. Maybe the imaging can help us out, and we are not very good at imaging newborns and small children. It's not easy in our institute. But what I have seen that the vision don't improve beyond a further limit in very high myopes. And as Dr. Lekha has mentioned, like what we have seen that unilateral myopia is very common. In cases of trauma also we see unilateral myopia. So maybe, as Dr. Anand said, it's a mechanism of the eye to grow and protect vision. So that could be the reason for any insult on the eye, they will end up with a myopia. That is quite common. Now, glaucoma, I have rarely seen glaucoma after ROP. Only one case I have seen, and that child is comfortable with topical drops. We didn't have to go for surgery. And lens changes also, cataract also I have rarely seen after ROP, but of late I have seen one case which was laser was done in UAE, came immediately to us with burns on the iris as well as an localized cataract, and we waited, but that cataract progressed and we had to operate the child at 6 months of age. That child is now I think 5 or 6 years of age. Definitely it has developed amblyopia because it is a unilateral one, but we could do a cataract surgery at 6 months and later we put a secondary IOL. And of late in the last 2 years I have seen just 2 cataracts. And the thing is, both these children came to us at 3 years of age with the parents giving a history of white reflex. And they came with cataract, and when we examined on slit lamp, we could make out that it was not a congenital cataract, nothing like a lamellar or posterior polar. And on slit lamp examination, we could see the PC dehiscence. So the parents had forgotten about the prematurity and all the treatments that had undergone, because it was like 2 years and 3 years, 2 babies. They had come at an interval of 6 to 7 months, I think, and it was unilateral, and they were given Avastin. So this we have to be careful about. Careful about, like here you can see the PC dehiscence here. So the one surprise is that the patient developed total cataract only after 2 years. And also the child was not amblyopic. We could assess the vision, and one child has a better vision in this eye because the other eye is high myopia. So such trauma to the lens has to be avoided during anti-VEGF. It can happen to anyone because we do it under topical, and the anatomy of the newborn is so delicate that you have to be very careful while introducing the needle, that the child can move the head, and it's really difficult to do it without anesthesia. And also you need a timely referral to other specialities for the global development of the child. That is also important. Then we had done 2 studies, one to assess the ocular sequelae in retinopathy of prematurity following laser photocoagulation. And just like the literature, it was mainly refractive errors. And the second came strabismus, but it was mainly myopia and high myopia in the case of aggressive ROP. And based on this, we did a study to compare these myopes with the full-term myopes. So what we have seen that we had compared children at the age of 7 to 15 years, and we have seen that the preterms with lasered ROP, they had increased lens thickness, shallower AC, and a lesser wide to wide corneal diameter in comparison to the full terms, where we saw more of the axial length was the reason for the high myopia. So literature also mentions, and we feel that it's altered anterior segment development, which is a key factor for the refractive errors, and also the literature also says the lens thickness is a key factor, but the axial length too contributes. So to summarize, I would say stress on the need for long-term follow-up, be more aggressive in the follow-up of APROP, AROP, ideal to keep a ROP directory so that if the parent forget, we insist. We used to do that earlier, but as the number grows, it's not easy for us to. But initial days I used to do that, I used to call back the patients, but now it's not easy, but still if you can keep a directory, it's really good. Thank you.
I think